Hello, welcome to another episode of Late Nights with Dr. G. You have questions, I have answers. Well, on this episode, we're going to be talking about cancer vaccines. What are they? Are they therapeutic? Are they preventive? How safe are they for the public? We're going to kind of get down to this because there's a lot of great work going on with these cancer vaccines, but how really helpful are they and are they safe? So we'll get to that today in this episode. Hey guys, I'm Dr. George Armendariz.
Actually, first to start off, I'll be going to Mexico tomorrow.
Oh, I like that.
Yeah,
I'm actually jealous. I would love to go to Mexico. I love Mexico.
I'll be there for a while. And so I know that you're from Mexico. You work with a lot of patients.
Well, to be fair, I'm from Texas. Okay, in the country of Texas, mind you. But I'm
your
Mexican.
Family,
I'm Mexican-American. My family, they were born here. My mom and dad were born here in Texas, but my grandparents, some of them were born here in Texas, and a lot of the family was born in Chihuahua.
Okay. And so you said you work with a lot of patients. You guys also work in Spanish as well?
I speak Spanish. I'm not perfect, but I understand everything in Spanish. And so a lot of the patients that come see me or that want, let's say, mostly cosmetic or aesthetic work, they don't even speak English. And so they feel comfortable with me because there's really not that many surgeons, cosmetic surgeons or aesthetic surgeons that speak Spanish. They usually have interpreters, and I have an interpreter as well. But I pretty much probably 85, 90% of the conversation, I can control it and be able to help the patient feel comfortable with what they're asking or what their needs are for treatment. And so that's one thing that I like to focus on because I think culturally, I understand what they're looking for and they understand me just because we're Mexican, you know.
So, so let's go into it. Let's talk about these cancer vaccines.
Okay, this is a great kind of topic just because, there's a new cancer vaccine. Now, I say new, it came out in the public where they made a story about it, okay? And it's for triple negative breast cancer, okay? If you look at all cancers in general, the most studied and the most funded cancer is breast cancer. And so, they've made huge strides in treatment and protocols and things of that nature for people, obviously women. Now, guys get breast cancer too, but obviously 98% of them are all going to be female. And so this particular article was about cancer vaccine that's in phase 1 trials at the Cleveland Clinic. And it's interesting to note that it's in phase 1. So they only used it's in human trials now, but they only used a small segment of the population and they focused strictly on triple negative breast cancers. That's the most aggressive breast cancer out there. People may kind of recognize that by Angelina Jolie. She had this type of genetically this type of cancer. And so now she didn't have breast cancer, but she chose to preventively get a double mastectomy because of this particular reason. Now, the reason they are working toward a vaccine for this one, and it's what's called therapeutic vaccine. It's not a preventive vaccine. And we'll get into that, the difference between the two. It's therapeutic in the sense that it just hits on a protein. That protein is alpha-lactalbumin. And so you're like, well, what the hell is that? Well, exactly. It is a protein that these type of cancers make up, and it's really selective for this particular type of cancer. And which is great because this is the most aggressive type of cancer. So if you can get a vaccine that can treat these cancers, man, that's a big win because the women that have these cancers, even if you get it caught early on, the remission is not that long. Usually they will come back, and a lot of times, a lot of these patients, they end up passing after 5-10 years, just mainly because even if they've got great treatment, just mainly because it's pretty aggressive. The cool thing is this is focused just on that particular protein. And what it does is it focuses the immune system to utilize the T cells, which are the natural killer cells. The T cells do the work. They're the ones that go in there and fight anything that in your immune system. The B cells remember. Okay, so the B cells can recognize, oh, wait a minute, that is foreign. We need to get that out of here, whether it's an infection or cancer or whatever it may be. And then the T cells go in and they go and clean it up and fight and, attach to it and destroy those particular cells. This is very, very selective, and that's what it has to be. In fact, they're utilizing these type of cancer vaccines. Now, granted, still in the research basis, along with immunotherapy. Immunotherapy is like very precise. It only allows you to treat usually a particular type of protein or cancer that it affects that. It attacks that. And so it helps in dealing with treating those cancers. Like what's the I always, we were joking before about hearing those little jingles with the pharmaceutical companies. Mm-hmm. Well, Keytruda, and I can't remember that one, but Keytruda I believe is for lung cancer. That's an immunotherapy. And so they're utilizing that along with certain cancer vaccine trials that are allowing it to really, it's like over 40% decrease in the recurrence rate.
What's the administration of this? How do they administer it? What type of vaccine would it be classified as?
Well, this one is a standard, like we were talking about, whether it's therapeutic or whether it's preventive. Now, let's kind of go into that. Now, really, there's two types of vaccines. Therapeutic is where it's actively treating after you've already had the cancer or you already got the infection, it goes in there and it actively treats it. It kind of works in concert with immunotherapy. Now, preventative vaccines are like the HPV. The human papillomavirus. Okay, that's what we give to kids. Now, that one works well because there are certain cervical cancers, anal cancers, and head and neck cancers that it prevents. Mainly because when the virus goes in, if you've had that vaccine and you come in contact with that virus, then it will attach onto it and destroy the virus before it can even turn into a cancer. And so that's a preventive. And that's what's great about those type of vaccines. And eventually we want to have all of our type vaccines be preventive. So you never really get those particular cancers. But the reality of it is it's very difficult for that to happen. Okay. And, those type of preventive vaccines are utilized because they use a kind of the shell of the virus. And it doesn't have any genetic material. It's just the shell. So your B cells within your immune system recognize it, and then your T cells attack it. And so it develops these antibodies to these particular viruses. And so you go in, and so if you ever come in contact with it, it immediately destroys those particular viruses before they even turn into a cancer. Okay, which is great. Although that's great, and that's an awesome thing that's happening. It's very difficult when you're talking about very specific proteins that you can attack. And so that's why this triple negative type breast cancer is, with this new alpha lactalbumin protein, man, it looks as though it's going to be able to recognize this type of cancer and kind of break it up or not let it flourish in the body and essentially kill it before it ever becomes something bad.
So so last time we were here, we spoke about AI and then the incorporation of that. What do you see as the potential for this in the future with like we said, the blood work and AI and the way that we could recognize patterns?
If you ever watched the Marvel comics or Marvel movies, you saw how Dr. Strange was able to kind of figure out 14 million different endings to what happened, and he found only one in which the Avengers beat Thanos. Okay, AI can do that, and you see how fast he's looking all kind of weird, looking at all these things, trying to figure out which one works, trying to find what future will work. Well, AI can kind of do that in a very obviously loosely way. It can figure out what we need to look for, how we need to look for it, what markers within the blood, tissue, or whatever can distinguish that or find something that's only distinguishable. Those cancers have one marker that it can find that says, okay, if we affect this marker and we treat this, it won't ever turn into a bad cancer or turn into something that can kill that particular patient. And so AI is going to be able, it's going to cause these researchers to be able quickly to find ways and protocols to develop these type of treatments, vaccines being one of them, but also immunotherapy treatments. Like I said before, gene therapy is going to be huge because they're going to affect our DNA. And that's the same thing. Moderna, has a bad rap right now because of what it did with the spike proteins and
mRNA,
the COVID vaccine. Okay. Globally, there's about 60 trials going on with mRNA vaccines. And these are all for cancer, various cancers, glioblastoma, pancreatic cancers, even I think they're colorectal. There are a lot of different cancers. Obviously, breast cancer is the one that's mostly studied and best funded. And so that one's being worked on. And they've made more access or they've gained more territory in that particular cancer than the other cancers. But there's ongoing research going on and trials, all human, that are going on with these different types of companies that make mRNA, immunotherapies, as well as these type of therapeutic vaccines.
Yeah. So what do you see as right now the biggest use case in terms of like the modern day? I mean, is it something that you think that is usable now? Do you think that there's going to probably needs to be a lot more trial, right?
Unfortunately, all of this sounds great, and it is. I mean, it's making everybody in the oncology world very, very excited because we're slowly getting into that area where we can kind of know how to do this. If you can develop one or two, it's easier, and then utilizing AI to kind of get all the information and really put it into a more strict protocol so that you can understand it and progress with it quickly. I mean, it's very exciting. The reality of it is that this is those are the pros. These are the cons. It's going to cost a lot of money, like a whole lot of money. And even if they come out with something that it works, it's great, it's going to be $100,000 plus. Like we've talked about me getting treated with stem cells, it's going to be $250,000 or more. Maybe a little less if insurance pays for some of the hospital stay and stuff like that, but it's still going to be a lot of money. It'll be definitely over $100,000, that I would have to pay out of pocket. Now, luckily for me, I have a job where, I have saved up that kind of money and I can do stuff like that, and that's something I'm hopefully, that I can do that and be given that opportunity. Most people can't do that. And so now you're like, who's going to be able to utilize these type of treatments, which are so exciting, and they're so well researched. And I mean, it appears as though they work quite well. You have to give these, 5, 10, 15 years or longer to see how the people, after they've been given it, after those many years, how they're going to respond. Is the cancer going to come back? Are they never going to get cancer again in that particular cancer? And so that's the con of it. We have to make this access, give this access to everybody that develops cancers, but I just don't know how they're going to do that because insurance, once again, sees this as experimental and they're not going to pay for it. Maybe there might be a handful of insurance companies that might do it on a research basis, but I don't see that. I don't see that happening anytime soon.
So do you see the potential for the timeline to be shorter though?
Oh yeah.
In the future,
yeah.
Because I mean, there was normally like 10-year clinical trials, and maybe now in the future with technology, you can get to like 5 years.
Yeah, probably so. With AI, you're going to be able to do a lot of those things because, like I said, I gave you that example about Dr. Strange and the Avengers, how he was able to so quickly to figure out the outcome out of 14 million different scenarios. AI will be able to do that to obviously it's different. It's not that simple, but AI will be able to do that for us. And so we can speed up the approval rate of certain types of vaccines or treatments and such like that. So that's what's exciting about all that stuff. But what for me as a physician, I worry that, and I just, there's been movies all over, and we talk a lot about movies, but movies kind of show us potential, but also show us the positive and negative aspects of what could be in the future. And so I just don't think we're going to have a lot of people that don't have that much money will have access to these type of treatments if they do get, those type of.
It seems like that's like
cancers.
the trend of half the topics is that if all of the medical in the U.S. it tends to be like only accessible to people who have, higher tier healthcare or
Yeah,
can afford it.
or financially are able to do it, or they just know the right people.
Mhm.
People in high places.
What's your suggestion outside of the basic stuff? Like, yeah, we can work out, eat healthy, but what is your suggestion for people who are looking as a medical professional? If somebody were to ask you, like, hey, where do I get like top tier healthcare? How do I get it for a price that I can afford? Or if they're asking about certain things, like maybe you bring up experimental treatments, but they don't know where they can get it, how they can get it. What are ways that they can possibly like manage or get into that? Is there pay as you go? Is there like plan or options? You as a provider, do you have like connections? What's the
There's all different types of third party financing companies, and depending on your credit, and depending on all the things behind that. If you own a business, if you own your home, or you have a lot of equity in your home, or just different assets that you may have, yeah, there's you can always find a financing company that will do that for you. You can get a personal loan. There's a lot of things you can do, and some people have already have gotten second and third mortgages on their homes because they've had a lot of equity in it. If they were to get certain types of cancers or certain illnesses, to help pay for that. So can you do it? Yeah. Should you have to do that? There should be access everywhere, but there's a happy medium. That's where the, socialized medicine type of issue comes up. And that's a whole other podcast, and it's, and I have my ideas on it because I'm a doctor. Do I need to not get paid a certain amount of money just because of all my training and schooling? In other countries, their country pays for they don't have loans like we do in America. They don't have school loans, and so yeah, they make less than we do, but they don't have any school loans. We do. We have a lot of school loans. And in fact, if you're going to a professional school like law school or medicine,
you're paying like what $2,000-3,000 a month on some of those loans?
oh yeah, yeah, absolutely. Or you're just paying forever. You're literally paying forever. If you work really hard, and you bust your ass and make a lot of money in a short amount of time, yeah, then you can pay 20,000, 50,000, 100,000, whatever, in a year. So you can make that amount lower and lower, and it will, hopefully you only pay for 10 or 15 years rather than 30 or 40 years. But if somebody was saying, how can I do that? There are other options. I mean, if you really don't have money, you can be a part of the Medicaid and Medicare type of insurances, but it's just
that's
not,
also changing all the time.
That's changing all the time. And
do you know anything about the new bill? Like I saw there was something about Medicaid getting affected by Trump's.
That particular bill, it's taking some funding away, some federal funding to particular states for things like that. And so, yeah, it's going to be affected. They're going to, which I can't argue that it's so wrong. Like every bit of it is wrong. Because, yeah, I don't want them to take away insurance for people that need it, but parts of the bill also state that you need to either volunteer or work 20 to 30 hours a week. You need to do certain things to maintain your ability to have that type of insurance. If it's a federally subsidized insurance, which most of them are in some form. So I can't argue that because I don't want people not working and living off the government. Maybe some people in the government want that, so they can control them. I don't agree with that at all. And I think people should work if they can. Now, granted, people are disabled and people can't work, and I get that. But there are a lot of people out there that aren't that sick, that aren't that disabled, that could, but they're still living off the system. And that is what hurts everybody that is working. I'm going to give you an example that broke my heart when I was doing a lot of anesthesia it was probably 2 or 3 years out. I was working at Maryville. Maryville Hospital is not here anymore. And it was like 3:00 in the morning doing OB. Okay. And so I was putting in epidurals in women that are laboring. And so I went into this first room, and it was this girl, second baby. She was young. She was probably in mid-20s, somewhere around there. And she was a manager at like a 7-Eleven or one of those convenience stores. And she was so immediately when I went over there, and this is the last thing somebody needs to be worried about when they're, in labor. How much is it going to cost? She had insurance, but it was, I think, like our Medicaid is called access. So she had access. It was a higher tier access, but it was access. And she was worried that, it wasn't access. It was an HMO. Sorry about that. And but it's still subsidized. And there's a lot of limitations to certain HMOs. And apparently she got it through her work and whatever. Anyway, so she was worried about how much is that epidural going to cost? And if she has to go to a C-section, what is that going to cost? And, some of those, I can't, 3:00 in the morning, I'm not the person to be talking to them. I'm just there to help them, to make them feel comfortable as best I can. And she was worried. She was like, well, if I can't pay for this, it's going to affect my credit, although I'll have a job, but then I won't be able to, get an apartment or maintain my apartment or get a car or, whatever. Whereas, so she's very stressed about it. Whereas I went across the hall and there's a patient that didn't speak English, did not have a social security number. And by law, we have to provide any, I guess, urgent or emergent treatment to these patients that come in, and they get what's called emergency access or emergency Medicaid. And so with that, I had to do an epidural that access pays me or pays my anesthesia group a certain amount of money to put an epidural in for that patient. As well as if she goes to a C-section, they pay me as well, or the anesthesia behind that, but also pays the OB-GYN doctor as well. And she has no repercussions from that. If she can't pay it, it doesn't matter. She doesn't speak English. She's somebody that's not an American that just came in. We provide that for her. So my quandary, and I'm Mexican American, and I want my people, if you can say that. My people are American because I was born and raised in Texas. Now we consider that a country, but that's neither here nor there. It made me think a lot, because this poor white girl that has a job and has insurance, but is afraid that she's not going to be able to pay because they only pay for a percentage of her bill. And then she'll still owe $2,000, $3,000, $4,000, whatever the bill is. She can't pay that. And her credit's going to be affected. And now she's going to have trouble providing for her kids. Whereas the person that's an illegal alien is coming in and they're not going to have a bill, because our state, as well as our federal government at that time, this is 20 years ago, they had something in place for that. So it's a quandary as a medical professional of me thinking, why does this American, with a social security number, why is she going to not be able to provide for her family? And she's from here. And she's doing everything she needs to do. She's got a job. She's got insurance. Yet she's going to be affected that way. And the person that doesn't have any of those things, including a social security number, is not going to be affected. So it's hard for me to say, well, what's right.
And it's not because one gets emergency medical help, which is needed, doesn't mean that the other, I think it's that the other, right, the American, shouldn't be getting charged to the degree that, or penalized to the degree that they are.
That's exactly
because
they shouldn't be penalized. They're both urgent or emergent, depending on whatever. They both have the same issues because they're laboring, right, about to deliver a baby. It's just hard for me to kind of comprehend that, even as a physician, because I just want the patients to be comfortable or treat them, and so they're well and they're doing okay. And it always creeps in, the financial aspect of it, and it makes people stressed out, which is going to cause you to get, have any more problems, different problems with more problems. And so I think about that from time to time. That particular story, it really hit me because I'm just like, man, it's not fair. I get it. People say, oh, we should have socialized medicine. But then again, I'm just like, socialized medicine, the countries that do have that, they have their issues too. You know, you and I had discussed, you know, in the UK, the junior doctors are on strike. They were going to go on strike for a whole week. It's mainly because they get paid, you know, if you compare how much they get paid as a junior doctor compared to our residents, I mean, it's you know, and we don't pay a lot to our residents either, but our residents can moonlight, you know, after a year. And so, you know, it's kind of crazy that I can't blame them for wanting more money because everything's going up. Why aren't they getting paid more? You know, they deserve to get paid more. They have to work, you know, sometimes every other night call and, you know, staying up over 24 hours.
They're still doing all the medical
They're
work.
Still doing all that. Everybody says, oh, we should make medicine socialized. It's not that easy.
It's like when there's too much stress it doesn't matter if it's on one end or the other end of the system is stressed.
It is a crazy, crazy system that has its breaking points and there is no answer. You can go on either side and you can argue whether we should have it or we shouldn't have it. Because then as a physician, I'm like, hey, you know, I put in a lot of time and I took out a lot of loans that I should be paid a certain amount to maintain my life, you know, and why is it unfair for me to get paid as a physician what I think I should be paid, especially if you look at the averages. That's hard. And you know who makes money? The insurance company. That's who makes money because they've been posting quarter after quarter these profits. And so that's what I don't agree with. And so they make us out to be the bad guy talking about the physicians, but they're hurting us as well as hurting because they're not approving these actually sometimes very simple procedures that these patients need, you know. And so it's a quandary.
Yeah, I used to work in health insurance and sell it, and one of the things I did like about it, and I don't love health insurance, but one of the things I did like about some of the plans was they incentivized people who would do like their blood tests, their blood
preventive
work,
medicine,
anything preventative, you would automatically get, I think, like a 5% discount.
That's what some, even like UHC and Cigna and Blue
Kaiser
Cross
and stuff. like that.
They're doing some of that, but they need to do that too.
They need to ramp it.
They need to ramp that up. You know, you see all these biohackers. What they talk about, some of the stuff, you have to have a little bit of money to do, but for the most part, we should have access to whole foods. That should be a God-given right to everybody. And I mean, good whole foods. I mean, you have to go even in our particular country, we have to go to a farmer's market to get that, or you have to go to a Whole Foods or Trader Joe's or something. You know, here at the grocery store, AJ's. It's great. It has all this awesome food. It's very expensive, you know. But it's a right that some people, that's where they should subsidize for people.
Yeah.
You know, and we talked previously about the EBT and the food stamps and everything, how you can get Doritos and chocolate milk and stuff that aren't good, Little Debbie's, you know.
They shouldn't be on there.
They shouldn't be on there. They shouldn't. There is no right or wrong answer, or I should say it's hard to find that right answer, but there are some simple things that they can do that they should allow us to do as physicians that would make people healthier and should benefit that person that is doing the right things to be healthier. Yeah. You know,
it's just incentivized.
By incentivizing them in some way. Well, you know, like maybe they pay less for the next quarter, you know, monthly or something like, I don't know. It's hard to say, but they don't want to, you know, come into affect their profits. And I get that as a businessman, but come on, man, you chose that particular type of business. So you need to be able to
I mean, like as a 20, like
something.
So I haven't been, I mean, you might not like hearing this. I haven't been to the doctor in 5 years.
I'm bad too. I need to go. Like we had a previous episode where I was like, shoot, I hope my cardiologist doesn't, you know, but at the same time, that's a lot of, just because for me, but I have training. And I kind of know what I should and should not do, you know, and if I need a particular medication, I can either call it in for me if it's, you know, not a scheduled drug, obviously, to help myself. People can't do that, like, you know.
So as a 20, I mean, but also 5 years ago, I was 25. Like I'm 30 now. I go to the gym every day. It's like I don't have too many reasons to check in.
There's no reason why. I mean, I do think that everybody needs to go at least yearly, if not every 6 months.
Yeah, I'm behind on that. But in terms of like, let's say, you know, in general, just for general purposes, you do your yearly checkup. Why is it that I have to still pay yes, I pay a lower rate. If you actually look at the way that you could disperse the system, I hate to say it, but certain people's premiums should be like $1,200 a month, and certain people's premiums should be like $80 a month. I'm closer to like the $100 a month, and they have to, do a certain, and they do groups, right? Like I know how it works with age groups and brackets, and it is quite substantial if you look at certain, like, 20s versus 50s, but they also, you're still paying. It's almost like the plane on the seat, it's like, because you're bigger, you get 2 seats on a plane, you get a free seat, versus like, well, who's going to get that cost? Everybody else on the plane is paying extra $5 for that person's seat.
It's a whole lot more than $5.
Yeah.
But I get it. No, I understand that. The sickest patients take up 95% of most of the monies in a particular fiscal year for an insurance company.
Mm-hmm.
The sickest patients, and that's only like the 5% of all their 100% of all the people that are under that particular insurance. 5% of them, the sickest patients, are the ones that take up the most money, 95% of the money. Or in dealing with, they're the ones going to the doctor, or they're getting these very, very expensive.
And that's why
treatments.
I think there should be some mandates, right? Like
it's hard to say. They've tried, and they tried with Obamacare, which was a total bust. It was not good at all. Patients, it wasn't good for the patients, wasn't good for the doctors, wasn't good for the hospitals. I don't care what people say.
It wasn't good for the businesses either.
No, it was horrible. It was horrible. And so, back in the 70s, and I'm going to blame HMOs for this. Back in the 70s, I was very poor. I grew up very poor. My mom had a 7th grade education. We didn't have much. She did great in a year. She made, $13,000, $14,000 of that year. The whole year, $13,000, $14,000. That's crazy. I mean, like, I wouldn't even, I couldn't live on that in a 2-week period. It's
that's
crazy.
Like basically like what, $30K a year nowadays, adjusted for inflation.
Yeah,
Probably
something like that. And that's even hard. $30,000 or $40,000 a year. That's difficult to live, And but we always had insurance, and the insurance, and we had, like, I remember having Blue Cross insurance. Okay, it was within the range. It was $120 or something, $140, and we had full coverage, and we could go and see a doc. And if we got hurt, we would get fixed, or treated or whatever, and now for basic coverage, you're looking at $400 or $500, and that's if you're super healthy, and now, and even then there's so many limitations on it. I have to, let me give you an example. I don't have it anymore, but I had an HMO here, and I'm not going to say which one, but it was an HMO. And, we were supposed to talk about vaccines, and what are we talking about? Of course, we go into talking about insurance. But I am going to tell you this story. I had this HMO, and I'm supposed to get an echo for my heart because I've got a known issue because I have a mechanical heart valve. I should get that. They wanted me to get a prior auth for an echo. And so what I did, luckily I could afford that. I just paid cash for it. It's a couple of $100, something like that, but I shouldn't have to do that. I should be able to not go through all of this red tape to get a simple echo.
Which is also already, they already know what you have.
They already know.
Yeah.
When I got it, I was like, look, I have a mechanical heart valve. The only thing I need is, I have to be on Coumadin, and I have to get an echo every year. And now I have to get a CT scan because I've had dilated aorta, or aortic root. And once again, prior auth. But you have to do that for every type of HMO. For simple things. Yeah. And so it's upsetting. And that's why I got rid of it. But I'm lucky I'm able to get rid of it and move on to get a different type of insurance. Most people cannot, and so that's a whole other story, a whole other episode that we're going to talk about that. Okay, guys. But let's get back to the vaccines, and I was the one to kind of deviated from that. But now vaccines, obviously I said they're either preventive or therapeutic. The ones that we talked about with the breast cancer, those are the therapeutic ones to actively treat cancers that are already ongoing. Okay. And then, of course, the preventive ones are like the HPV vaccine, the Gardasil is what it's called. And those are awesome. And there's a ton of standard vaccine that you get the protein core without genetic material. That's like the polio vaccine. Your immune system remembers it. Then whenever it comes in contact with that, it can destroy it before it even starts and becomes anything, becomes any type of cancer.
Those are those vaccines that you get like when I was a teenager, they were
You're
like,
exactly
there's
right.
a new one for
Diphtheria,
genital warts. They want to do like 10 years in advance.
Yep. And that's like the HPV one. Okay. It's not, genital warts is not that one. I mean, it is up to a point. It's not all of them, I should say. There's a lot of different strains for that stuff. But for the most part, it's the ones that can cause those problems more frequently.
Yeah, I just remember they offered it. They were like, hey, you should get it.
Yeah.
You're, whatever.
See, I never had that, but it wasn't available when I was that age. And now they've stopped it at 42, which they don't give a great answer to why. I would think somebody even at 55 can go ahead and take these vaccines, but mainly I think it's just because I've come in probably contact with that somewhere.
Now, quick question about the vaccines. How do you feel about vaccine injury? That's a very big thing.
What do you mean by vaccine injury?
There's a lawyer here in Scottsdale who works with RFK, and he talks about the vaccine and vaccine injury.
Okay, I know what you're talking about. You're
since
talking
we're on
about
the topic.
Since we're on topic of vaccines, vaccine injury is meaning, did that person develop an issue from the vaccine? And we're talking about the COVID vaccine, because regular vaccines have been around for decades. It's not them.
So that's not like a regular risk in terms of like.
No, but it was like I told you, there's 60 ongoing mRNA vaccines. Those are very precise, precision type vaccines, which it's great. But you have to understand, with mRNA, it changes your DNA. And so there's things you have to look at, and things that are very good about it, but there's also things that are negative about it. And so can people be injured? Yeah, there's a potential for that. There's a potential for anything that can injure somebody.
What about the autism and the
Who knows?
The things where they're saying
you can't prove that, but you can't disapprove it either. Because it's if you look at, once we started using certain vaccines or certain treatments, that patients now, there's a big up. Man, when I was growing up in the 70s and 80s, I never really heard about autism. We had it, but we never heard about it. Now, every other kid has autism in some form. High functioning. I have very close people in my life and family that have that. High functioning, but they still have it. Or at least that's what they've been diagnosed as. And so it wasn't there back in the 70s and 80s, and even the early 90s. The early 90s is when it started getting kind of building up, and then obviously the 2000s and so forth. And now we have all these treatments, and then like for ADD as an example. And once again, we should be talking about vaccines, and we start getting off on different tangents. ADD, for that matter, I had ADD. Well, at least I'm assuming I did. What did I do? I did gymnastics. Worked out great. A lot of my friends had ADD. What did they do? Football, basketball, volleyball, whatever. Yes. What do we do? We give them drugs. And I get that, and I understand now, that it's a part of it now. I'm not saying it's bad, because my kid was on it, but these are just things that you have to stop and ponder and think about. Why are we giving them this? And there has to be a better way. And so going back to all the vaccines are great, and we need more of them. And I'm glad they're having a lot of money in dealing with funding to make these happen. And so we have to think about how good they are, but we also have to think about the negative parts of them. And I'm not talking about the COVID vaccine. The COVID vaccine is an outlier. And the main reason why is because it was made in 18 months. I can't trust anything that's made in 18 months. I really can't. And that's why you're having so many problems. And so that's why these lawyers want to sue for people that are having issues with it. And I understand that. It's not a vaccine that has been studied. And most vaccines take 10 years at bare minimum, and obviously we didn't have that time. And did it save people? Probably. It probably did save people. But did it hurt people? Yeah, it did. And there are people that are still having issues from it. And so there's a lot of pros and cons when you're talking about vaccines. The cancer vaccines, I think it's great. And I think we're going to have the potential, especially utilizing AI and those type of programming and preventive and precision medicine. All that stuff's going to be great. But we got to take everything with a grain of salt, because things
What do you think the new age of, like, the new average age of death is going to be in the next 30, 40 years?
If we can get our shit together and do what some of these biohackers and do what some of these doctors are telling us to do, with preventive medicine and just being healthier, it should be longer. But unfortunately, even over the last probably 15, 20 years, and mainly because of the COVID pandemic, our survival rates have gone down, especially for men. Women kind of maintained, but they went down as well.
They kept saying like we're gonna get to the point where people are living to 120.
Oh, we should already be. The human body should already be able to have people live to 150, but that's where you're talking about the food, your environment, the pollution, all this other stuff. That's why we're not living that long. And so
there's stories, right? Like the Bible, people who've lived to 120, 150.
They were living over 1,000 years. Now that's the Bible, and you got to take that for what it is, and depends on what you believe in.
Yeah.
But even back then, people were living long, in which we said, no, our history shows that people lived to 49 or, in their 30s. Did they? Because really, the Bible is only somebody's opinion of what they remember or what they, they're just stories. I'm not saying they're wrong, because they're probably not, but you've told a story, and then I can tell that same story, and we're going to tell it differently. And so that you got to think about that. Now, this episode, we kind of covered vaccines. Now, unfortunately, we need to go on tangents, and a lot of that is my fault, so I apologize for that. But that being said, we kind of just focused on cancer vaccines and how good they are, but also some of the negative things about them, as well as, what's therapeutic, what's preventative, and how important are they in dealing with treating cancer, but also, how good are they, but also what are the bad points or the cons of these type of treatments. Everything has its issues, and I'm talking everything when you're talking about science or medicine, but at least it gives me hope. And hope is the most important thing that we have in medicine, that we can develop these type of vaccines so that people can get better, or we can prevent any of these horrible cancers. Now, stay tuned for us for our next episode, which I'm hoping to have a guest so that we can discuss some of the issues talking about cancer, and perhaps kind of figuring out how we can do things differently, especially me as a medical professional, but also as the general public, on what they can do to prevent issues so that they don't develop cancer. So stick with us.